I needed to read up a little bit about this topic. When I was in residency, hypothermia wasn't quite a real established treatment since it's been about a decade that therapeutic hypothermia has been routinely used according to guidelines. And the field of continuous EEG recording has also really taken off over the last decade. So I'm going to try and link these two together a little bit. In our hospital here, we see a fair amount of patients that get treated with therapeutic hypothermia, usually in the setting of cardiac arrest. And at this point, we don't really routinely utilize immediate assessment with EEG. We do our clinical assessments, we do the protocol of hypothermia, and we sort of wait for any type of management decisions until the hypothermia protocol has terminated. But I'll show you that there's probably some benefit of trying to incorporate EEG readings even during hypothermia, and why that may be useful. Just last month, there's been a published guideline, not a sort of parameter, but a consensus statement from the task force that was pulled together by the American Clinical Neurophysiology Society. And some of the data that I'll show you comes directly from that just came out in the journal last month. But all of it is still very difficult to interpret because there really isn't a lot of prospective randomized trials that look at the utility of continuous EEG recording, specifically in the setting of cardiac arrest and hypothermia treatment. I want to define a few things because healthcare staff that works in the intensive care unit may see continuous EEG monitor sitting at the bedside, and the word of continuous EEG monitoring, I think, brings to light as if someone's monitoring the brain waves second by second, and that's really not a practicality that most centers would be able to achieve. Typically, continuous monitoring can be done in an epilepsy monitoring unit setting, and even then it's usually only done if there's patients that need to be watched for the occurrence of an isolated seizure if they require an injection with a radio tracer to perform a SPECT scan, but that's really not feasible in the setting where you're doing monitoring in an intensive care unit. So typically, due to the resource limitations, the EEG runs continuously, but it's assessed usually twice a day, sometimes 3 times a day, by the combined efforts of a technician and whoever is in charge of reading the EEG. It can be the neurologist who's on the case, or it can be, if that particular neurologist is not comfortable reading EEGs, it has to be someone else who really may not be on duty in the hospital. So the logistics of it require sometimes a little bit of improvisation. What most of the data is pulled from is really looking at a standard 21 electrode application, which is initially put on the patient by a skilled technician and also maintained daily. Long-term continuous EEG recordings can be done, but after a few days, patients often need a bit of a break to their scalp. It's wrapped really tight. There can be breakdown of the skin from the electrode, so it does have to be checked daily, and it's pretty labor intensive. Usually our technicians would work on a patient, half an hour a day just to maintain it and keep any type of a good quality recording going. And this becomes a little bit more important in some of the reasons why we would want to have this information. When they have done studies in the past trying to incorporate continuous EEG recording into critical care using very limited application, it becomes very difficult to interpret. I think for most neurologists who are comfortable reading EEGs, it's difficult enough to read information if you have complete information. If you're going to take away the detail, you're left with a lot of guesswork. Let's see. So what can we use EEG for in the neuro ICU? So particularly any type of changes in the patient's clinical condition that are associated with sort of repetitive or paroxysmal movements or posturing or subtle twitches can be difficult to assess clinically what it may be due to. Often it happens maybe for a few seconds, and by the time you want to look at it, it's gone. You get reports from nursing staff. They describe it in their words, and you're really not sure exactly what you may be hearing. Nonconvulsive seizures are really the pretty much only way to detect them is looking at the EEG, because they're by definition nonconvulsive. So you don't see much other than an obtunded patient who has a deterioration in their mental status. The assessment of treatment of seizures and how efficacious you are with that is well established. Continuous EEG recording has a well-established role in the treatment of status epilepticus, both to assess if you're treating the seizures accurately, but also the depth of your anesthetic levels are guided by the useful information from the EEG. Prognostication after cardiac arrest, and particularly during and after therapeutic hypothermia, or prognostication after traumatic brain injury and subarachnoid hemorrhage, the EEG can be helpful there. And I'll show you later in the slides a few pointers of what typically we look for on the EEG. Number 4 we talked about already. Number 5 is sort of interesting. We're not utilizing this that much at this point, but an EEG is a very good tool to detect cerebral, unilateral cerebral ischemia. It's well established in the setting of doing carotid endarterectomy, but in the intensive care unit, when you have somebody who is at risk for cerebral ischemia, such as in vasospasm after subarachnoid hemorrhage, the EEG could be very helpful. The problem there is that you need the information to come to light in a timely enough window in order to do something about it, and that's kind of where the problem is, because as I said before, we don't typically monitor this 24/7, and if from Monday to Tuesday, on Tuesday morning the neurologist calls the doctor that yesterday afternoon the patient's lost the fast activity over one cerebral hemisphere, that's completely useless information. If you would have frequent review, the data can be useful. And you can see that some of the studies have shown that if there's a window of a few hours during which you could report changes back to the treatment team, it can lead to valuable interventions. In a similar way that we do transcranial Dopplers or if needed angiograms in the setting of vasospasm. So this may be useful in the future. I think the logistics of being able to review the data in the real time would be much more helpful. If you have settings where the EEG is already showing significant diffuse slowing and it makes it difficult to pick up a little bit of an asymmetry, that may be where an EEG cannot be that helpful, but the role of this is not quite clear. We're not currently actively utilizing that here in our facility. With what frequency do we see the occurrence of seizures in typical patients that may end up in the neurocritical care unit? It's common. Just to give some scenarios, so everybody would probably understand after status epilepticus, following the convulsive state, the period of status epilepticus, about 50% of people still have notable seizure activity that is ongoing that you may or may not be clinically aware of. After subarachnoid hemorrhage, any seizures are seen in about 10 to 20%. Nonconvulsive seizures maybe a little less frequently, but harder to detect. Intraparenchymal hemorrhage, the number is about between 16 and 23%, and traumatic brain injury and CNS infections and recent neurosurgical procedures, more or less the same numbers. Brain tumors, any seizure detection, around a quarter to a third of the patients, and nonconvulsive seizures a little less frequent. Ischemic stroke, the numbers vary somewhat, so different studies have found different numbers, but they're all substantial numbers. I mean, these are not infrequent. Hypoxic ischemic injury after cardiopulmonary arrest, with or without the use of therapeutic hypothermia, the numbers vary widely, 10 to 60%. Sepsis-associated encephalopathy, about a third of patients, and that's particularly a bit difficult sometimes for neurologists to review the EEG, because deep encephalopathy sometimes gives patterns on the EEG that are very similar to nonconvulsive seizures, and in both scenarios the patients are having severe altered mental status, and it's sometimes hard to see the difference on the EEG. And then any epilepsy-related admissions where the patient may not be in status epilepticus anymore, but following recurrent seizures or the use of multiple medications. For children, these numbers can pretty much be doubled, so that's very impressive. The nonconvulsive seizures have been clearly shown to be associated with increased mortality and increased risk for poor neurologic outcome. The question at this point is whether aggressive treatment of that is changing the outcome for people who have these in the setting of, particularly in the setting of cardiopulmonary arrest, and treatment with hypothermia following that. Nonconvulsive status epilepticus has a variable definition, so that's a little bit difficult to find uniform language to describe that, but at least for now we adhere a little bit to describing that as more than 30 minutes of nonconvulsive seizure activity seen on the EEG, or recurrent seizure activity over the period of 30 minutes with an altered mental status or no return to baseline in between. Seizure activity seen more than 5 minutes on the EEG, or if you're seeing it in more than 50% of the time that you're recording your EEG. It's a little difficult without a uniform definition there, but I think most of the time neurologists that are comfortable reading EEGs can sense that they're dealing with nonconvulsive status epilepticus or recurrent nonconvulsive seizures. How useful is a typical EEG recording, and how does that compare to hooking people up to a continuous monitoring? About a decade ago, this research started to come out that in the patients that are critically ill with a neurologic problem, that if you do a spot site EEG, those patients that are eventually going to declare themselves as having seizures during the hospitalization, about 50% of those you'll pick up with a spot check EEG. So that's still very useful. But you can double that amount by recording them for 24 to 48 hours. So if you haven't seen seizure activity in someone who you do suspect may be having seizures, by recording them for 24 to 48 hours in the setting of any type of injury that is associated with seizures, you can feel a lot more comfortable that you're probably not going to capture that. So it is more labor intensive, more time consuming, but it does increase the yield tremendously. You can probably do the same thing by doing serial EEGs once or sometimes even twice a day, depending on your level of clinical suspicion. So those haven't been clearly compared side to side, and depends a little bit on the logistics of your facility where you work, if it's easier to do serial spot check EEGs depending on technologists and machine availability versus dedicating a machine and leaving that at the bedside. Some hospitals don't have more than 1 or 2 machines, and if you have one blocked in use, that the other things you need to do with the machine may suffer. If we treat seizures in the setting of ischemic encephalopathy, what kind of outcome could we expect? This is pretty hopeless, in fact, but there haven't really been good prospective studies. So in one study where 139 patients were treated with some form of anticonvulsant treatment in a very non-standardized fashion, and out of those, 24 had bona fide status epilepticus. 23 out of those 24 patients that were treated for status epilepticus, and this is in the setting of cardiopulmonary arrest and the setting of treatment with therapeutic hypothermia. This does not reflect the general population of status epilepticus, but particularly in the setting of cardiopulmonary arrest, almost all died. So does it mean we shouldn't treat it? Well, the problem is we haven't particularly looked at standardized treatment, and out of this group, the patients were given medications that were deemed appropriate by the treating physicians, but they really didn't get these patients aggressively into a burst suppression pattern or follow typical recommendations that would normally be used in the setting of status epilepticus. So even though this is very sobering information, I think that more future trials are needed to see where it leads us to make a plan to treat patients that are undergoing or have already finished therapeutic hypothermia and are found to have status epilepticus or seizures. Let's see. Hypothermia has obviously lots of interesting effects on the brain and on the EEG. So hypothermia itself doesn't actually have a lot of strong effects on interpretation of the EEG. The EEG brainwave activity slows a little bit. It has a bit more of a theta range power, which is the slower brainwaves. But you can also see some accentuation of the beta range power, which is the faster brainwaves, which is almost a little bit contradictory. And we can see from clinical evaluations that mild hypothermia, which is what is used in our protocols, can actually have some electrographic changes that are more consistent with, at the same time, hyperexcitation and also decreased electric activity of the brain. But the overall effect on seizures is that it is somewhat mildly seizure suppressing. So it acts a little bit as its own treatment for seizures, which is probably why we more commonly see seizures during the rewarming phase or directly after. It is possible to see them in the midst of the hypothermia phase, and that is probably more reflective of the degree of underlying cerebral injury. What we also know, and I'm going to go into that next a little bit, I'll stand here at this point for a second, that if seizures occur in the rewarming phase or after the protocol is complete, there's some suggestion that treating those seizures may have a bit more of a possibility for good neurological outcome if you couple that with some signs of clinically preserved brain activity during the hypothermia phase, as well as presence of reactivity on the background EEG. And that last point, I think, is quite important. So I'll give a bit of information about that as well. So we know that EEG, let's see if I stand with this slide or the next one. This we pretty much talked about. Here, this is what I want to talk about a little bit. If we look at some prediction of what the EEG can add, a recent study done in the last couple of years has combined 4 of these parameters, and if you have 2 of these parameters, you can make a fairly good judgment on outcome for a patient who has suffered cardiopulmonary arrest and has gone through the hypothermia protocol. And some of these parameters you can obtain during the phase of hypothermia itself, and that is a non-reactive EEG background. So that's, throughout a couple of different studies, has become a good extra piece of information to take into consideration. There's almost never a scenario where a persistently non-reactive EEG background, and that does not mean a flat EEG, it just means that we don't see a change on the EEG when the patient is stimulated. That's what non-reactivity means. If we see that together coupled with one of these other parameters, people do not have hope for a good recovery. So the incomplete presence or absence, I guess, of brainstem reflexes, somatosensory evoked potentials, and the presence of myoclonus, you got 2 out of these 4, people do not do well. And this is at least information that has been accumulated in the era of therapeutic hypothermia, because a lot of information was before that era, and it is just difficult to interpret that now that we use this as a standard treatment. Other studies that have more looked at specific EEG patterns that convey a poor prognosis include an isoelectric pattern, flat EEG, burst suppression pattern, which isoelectric EEG and a burst suppression pattern are typically non-reactive patterns on the EEG, so it more or less conveys that same message that the EEG is not reactive, it's invariable. Periodic patterns and electrographic seizures are also poor prognostic factors. Favorable patterns on the EEG, which can actually be seen during hypothermia, because they're not so much influenced by the hypothermia, includes background continuity, so the EEG is continuous. It shows whatever activity, but it shows that continuously without periods of diffuse attenuation. Spontaneous variability of the EEG, so we just see pages of higher voltage recording and then a little bit lower, and it sort of alternates. Even though a burst suppression pattern is also a pattern that alternates, it's an invariable pattern, and we don't sort of classify that under spontaneous variability. Reactivity to stimulation is probably the most important one, and if we see sleep patterns on a continuous EEG, that really indicates an integration of higher level electrical systems in the brain that convey a good prognosis. Now the problem with those is they have a pretty high false positive rate. There are so many other pieces of information that have to come together for a patient to have good outcome that it's hard to put a strong positive prognostication on the EEG alone. So we do often see that the EEG looks really good, but the patient doesn't. This is a reactive EEG. You can't read the little black blip on the top, but it's basically a loud clap, or you can use a painful stimulus. And any EEG recording in an intensive care unit scenario is not a good quality recording if it doesn't include the patient being stimulated. The usefulness of the EEG is much lower if you cannot establish if there's reactivity to stimulation. And this would be classified as an EEG that has some diffuse background slowing, and then there's an electrodecrement, sort of a lowering of the voltages when there is a clapping, and that's a normal response. The EEG is not normal, but the response to the sound is normal. This is an unreactive EEG. This is a burst suppression pattern. You can give a stimulation here, but the pattern does not change. Sometimes you have to do it a few times, because if you see a burst occurring just at the time of the stimulation you give, you may interpret that as, oh, the EEG changed. But if you do it repeatedly, you can see if this is variable at all or not. This is also an example of a non-reactive EEG, even though it is continuous and it has a variety of theta, delta, and mostly alpha recording. It doesn't change with the stimulation, and that could be consistent with an alpha coma, which could also generally convey a poor prognosis. So establishing reactivity is probably one of the key components of doing EEG recordings for any purpose in the ICU. Again, reactive EEG background has been shown in multiple studies to have strong prognostic predictive value, and studies have also shown that that quality of the EEG is robust in the setting of therapeutic hypothermia. Although we use measures for sedation, and we use measures for shivering, there generally are other effects in the ICU to deal with. You're almost never will be able to do an EEG recording in the ICU in a patient who does not have some degree of psychotropic medications on board and is not to some degree encephalopathic. So you have to incorporate all of that when you look at the prognostic information you can get from the EEG. But hypothermia itself, the effect is relatively mild. When this was studied in a standardized fashion, trying to grade EEG abnormalities in a scale from 1 to 3, and the scale level of 3 had most of those bad prognostic patterns that I just talked about: isoelectric pattern, burst suppression pattern, non-reactive EEG. If they looked at that before or during and after hypothermia had been completed, they saw that 3/4 of the patients really did not move in their grade scale. The EEG in most of these patients remained more or less the same category of severity of abnormalities. I guess you could use that, look at it differently and say, well, 25% of the patients apparently it did have enough of an influence to grade their EEG changes in a different category, but it does mean that it gives you prognostic information, and that whatever you see during hypothermia is not going to be likely influenced greatly just by the hypothermia and the other factors that come along with the hypothermia, the level of sedation, the medications, that it influences that too much. Some things that happen in the brain during hypothermia that affect the EEG in particular, many things happen, but not everything affects the EEG, is that some medications that have a strong effect on the EEG have a changed metabolism directly as a result of hypothermia. pH increases a little bit. Some drugs that may have a certain degree of CNS penetrance may have a bit of a different degree of CNS penetrance that you can't really predict just from their pharmacokinetic profile. So to some degree, you really do need to know what your patient is getting at the time of the EEG recording, so you can incorporate if you feel that that may have a significant influence on the EEG or not, specifically when there's also multi-organ failure or other issues that will significantly alter EEG recordings per se, or metabolism of drugs. So EEG and continuous EEG are useful. They're really useful in the neuro ICU for many different reasons. Some of the goals I think we will see more benefit from in the years to come if some of the logistics issues and the high cost and the labor intensiveness of this diagnostic procedure can be simplified somewhat. One of the problems is because we do see poor prognostic patterns on EEG have generally, in the studies we have thus far, a high prediction for poor neurologic outcome. The problem, though, is because we have so little prospective studies, is that utilizing that information during the phase of hypothermia and trying to predict that a patient will have a poor positive outcome can be a self-fulfilling prophecy. So the recommendations at this time are that even if you want to utilize prognostic information from an EEG during hypothermia, probably don't let it change your management too much until you really put it together with the patient's condition after hypothermia is completed, as well as other parameters. So use it in conjunction with. That being said, as if you remember one thing from this lecture is probably that the presence of an unreactive EEG, no matter really what the circumstances of the patient, if they're having renal failure, kidney or liver failure, or if they're in the midst of hypothermia and they're getting medications administered, it really conveys a poor outcome, and that's a pretty robust finding that multiple studies have been able to repeat. One disclosure, and there we go. Are there any questions? Yeah, it would be wonderful if we could incorporate that with a reliable way of extracting sort of automated information from it. And you can probably pick up you can pick up non-reactive EEG easily on a simplified EEG montage, but that's only one piece of information you get from EEG. So if you're looking for spontaneous state changes, if you're looking for sleep, and if you're looking, certainly if you're looking for localized seizures, which we do tend to see fairly commonly in, not particularly in after cardiac arrest, but in localized brain disease, you're going to miss those, and you're going to probably derive, a false sense of security from that monitoring. So we're not there. We can't really utilize those. They're being developed, and I think, as they're being developed, they may have a role to play, but they're, I don't think, anywhere near extracting a lot of useful information that would compete with even a spot check EEG or a serial EEG. That would certainly be preferable over a very limited montage EEG.
If you were to think about sort of an algorithm to use EEG in the setting of hypothermia, what would that look like?
Well, you can do spot check EEG during hypothermia. Now, the patient is probably when they're at goal temperature, you can do a spot check and see if they're reactive. That's probably already a useful piece of information that comes probably 24 hours before you're going to have more clinical information. And it's robust enough to not be influenced too much by whatever you're using for your sedative or your paralytics, because you really have limited way of clinically evaluating these patients before they're warmed up again.
I think it has to be kind of on two purposes, the use of the algorithm. One is for prognostication.
Yeah.
The other one would be for...
For detection of seizures.
Treatment of seizures.
Yeah.
It seems like for the treatment of seizures, there's not much of a role.
No, not at this point. No, the thing is, you know, everybody's got their unique one patient who's had status epilepticus in the setting of a cardiac arrest and has walked away from it, and it is a possibility, but whether detecting that 12 hours earlier than what you normally would do, because you detect that anyway, because once they're warmed up and they're not doing anything, you're going to do an EEG then. So whether even a time lag would have an influence there, it doesn't even seem to have an influence now when you're trying to detect it early. So we need prospective studies on that. If you're seeing someone having clinical seizures, it probably is very useful to look at that and try to aggressively treat that. It's not harmful to try and do that. The problem is how do you utilize any of your algorithms for the typical treatment of status epilepticus, which are really not suited for this. And you're going to end up trying to decide if you're going to put people, you know, on trying to get them in a burst suppression pattern for 2 days after they've already had hypothermia, and how they're going to tolerate that in the setting of whatever other injuries they have. It's difficult to see the role for that if there hasn't been anything that has conveyed a positive outcome for that.
All right. Well, thank you very much.